All right. Well, hello, everyone. My name is Matt Whitaker. I'm here with Compassionate Choices, and I'll be hosting today's webinar. We are a few minutes away from officially launching into things, but wanted to give you a moment to make sure that you knew that you were in the right spot. So in about 3 minutes, we will start our webinar formally. So you've got a little bit of time to grab another cup of coffee or hot tea or whatever your beverage of choice is, to settle in, get comfortable, and then we will get started with our webinar shortly. We are glad that you're here with us today. Glad that you're able to make it in. And in about 2 minutes, we'll start with our formal program. So just know that you are in the right place. So in about 2 minutes, we'll get started introducing our speakers and going. Again, if you are just now joining us, I see that our attendees are trickling in. Welcome to our Compassionate Choices webinar today on COVID-19 and how it's changing end-of-life care. We're glad you're here. We've got about 2 minutes until we actually get started with our broadcast. So just want all of you to know that you are in the right place. Glad that you're logged in, and you've got another minute or two to, as I said earlier, pour yourself a cup of coffee or tea and to settle in and get comfortable before we start with our webinar. So we are glad that you're here, and glad that you're here early, and excited to get started with, I know, what will be a really exciting discussion between our esteemed panelists today. So the countdown is on. We've got about 1 minute until we formally start our webinar today. Again, if you're just now logging in, I see that we've got more and more attendees who are joining. Thank you for joining us. My name is Matt Whitaker, and I'll be serving as the host today for our webinar on COVID-19 and how it's changing end-of-life care. We've got just about another minute until we get rolling with things, and you get to meet all of our panelists who will be speaking today. So you've got a moment to get comfortable and settle in, but just know that you're in the right place. We're glad that you're logged in and ready for this webinar, and we are excited and honored that you're spending this little piece of your day with us. So the countdown is still on. We're going to give folks about 30 more seconds, and then we will formally start our program. So again, thank you so much for being here, and we are glad that you're here. You are in the right place, and we are about to get started. And with that being said, you know, I'm looking at my clock, and it looks like we are at our official launch time. We want to be respectful of people's time as people are joining in and taking time out of their busy days to be a part of this webinar. I want to go ahead and formally welcome all of you to today's webinar, our latest offering in our Stronger Together webinar series called How the COVID-19 Pandemic is Changing End-of-Life Care, the clinician perspective on the good, the bad, and the way forward. My name is Matt Whitaker. I'm the Director of Integrated Programs at Compassionate Choices. It's my honor today to be with all of you as we open up our homes and join you in your homes to talk about this really important topic. We have an incredible panel of panelists today that we're going to introduce in just a moment. But before we jump into that, I do want to talk through a little bit of housekeeping so that you know what to expect. The first thing that I just want to make sure that everybody knows is that we are recording today's webinar. And so we want to make sure that you're aware of that, but also that you're aware that all of our webinars that we've done in this series that we continue to do are recorded. And at the end of today's webinar, we'll talk more about how to access those on the Compassionate Choices website. The other little bit of housekeeping is that today, you know, we've got an hour, and we want to make sure that we cover as much as we possibly can, and that we answer as many of your questions as we possibly can. So if you have a question at any time during today's webinar, you'll see on your Zoom screen there is a chat box feature. If you'll open up the chat, type your question there, we'll make sure that we get to as many of those as possible in the second half of today's webinar, again, so that you have a chance to get your questions answered by our panelists. One other thing that I want to say before we introduce those panelists is if you are new to Compassionate Choices, welcome. Compassionate Choices is the nation's oldest, largest, most active nonprofit that's working to improve care, expand options, and hopefully empower everyone to chart their own end-of-life journey. And if you're just now meeting us, we are excited that you're here with us today. And for those of you who have been supporters or volunteers for a longer period of time, again, we are so grateful for you and for your engagement today and for the fact that you are allowing us, again, to join you in your homes and talk about this important topic. So if you're new, we welcome you. If you're a friend, we welcome you back. And with that, I am excited to introduce today's speakers and our panelists. The first of which was just Kim Callanan, who is our president and CEO here at Compassion and Choices. And Kim has done so much during her tenure at Compassion and Choices to, again, work towards that reality of ensuring that people are able to chart their own unique journey at the end of life, including authorizing and implementing new medical aid and dying laws in 5 jurisdictions, including California, Colorado, DC, Hawaii, and New Jersey. She's worked on drafting and promoting and implementing Compassion and Choices' innovative new strategic plan. And she's worked to really be the leader in launching our new Finish Strong initiative, which includes this whole new suite of tools targeted at people who are looking to find empowerment as they look at the end of life, including those with dementia. And Kim has spearheaded and led that effort and thought leadership behind it in an amazing way. So we are so glad to have Kim, who's here and going to be leading our discussion with these panelists. We also are joined by Debbie Dunn. And Deborah Dunn is an operating room nurse who has been an operating room manager, has been a perioperative director, and is currently an operating room educator in a hospital in New Jersey. And she not only serves in that capacity, serving patients day in and day out, she's also on the editorial board of the Operating Room Nurses Journal, has previously served as on her certification board of directors for 6 years. She's published over 40 articles, is a peer reviewer for nursing journals, and has presented on topics nationwide. And we're so lucky to have her with Compassion and Choices now. Debbie started volunteering with Compassion and Choices to pass medical aid and dying in New Jersey, which was a success, after her husband passed away, and she has been an active volunteer ever since. Her passion is really around educating the public about advanced healthcare directives and about end-of-life care options. And we are just so honored and privileged not only to have Debbie as a friend of the movement, but to have her today as a panelist. So welcome, Debbie, as well. We're also joined by Dr. Jeff Gardere, better known as America's Psychologist, who is a prolific author of multiple books and a contributing author of over a half a dozen books, including a brand new text called The Causes of Autism. In addition to being a recommended person in the academic space, Dr. Jeff is also someone you might have seen on television as a frequent contributor to the Fox Network, the Today Show, MSNBC, CNN. He was the host of VH1's Dad Camp and is a frequent guest on the Housewives of Atlanta and Potomac, on Love and Hip Hop Atlanta in New York. And he's also the principal psychologist on several different television programs. So we are so lucky to have him with us today, America's Psychologist. He's also, outside of his work as a widely sought after expert and a person who holds a private practice in Manhattan, an associate professor and course director of behavioral health medicine at Truro College of Osteopathic Medicine in New York City. So we are so fortunate again to have our esteemed friend, Dr. Jeff, on the panel today. And then last but not least, we're joined by Dr. David Muller, who is the Dean for the Medical School at the Icahn School of Medicine at Mount Sinai in New York. In his work, he currently focuses on several different key aspects, including the impact of racism and bias on medical education, creating alternative pathways to medical school in an effort to redefine national standards for undergraduate and post-bac pre-med preparation. He also works to develop creative training opportunities for medical students who are interested in diverse careers in medicine. We are so excited to have Dr. Muller here as well to share his experience in New York. So thank you, Dr. Muller, for being here. So with those introductions out of the way, I'm going to sit back and enjoy what our panelists have to talk about, and I'll be back for our Q&A. Again, make sure you leave those questions in the chat box, and we'll get to just as many of them as we possibly can. So Kim, take it away.
Thank you so much, Matt. It is truly an honor to be here and to be among such esteemed colleagues. Really tremendous background that you have so generously agreed to contribute on this call. Good morning or good afternoon, depending on where you might be. As we start today, I do want to just take a moment to acknowledge the very tragic circumstances of the past few weeks. These circumstances once again really do shine a very glaring light on the alarming racism and discrimination that plague our country. And while criminal justice issues extend beyond the mission of Compassion and Choices, at Compassion and Choices, we are very committed to doing all we can to achieve racial justice and equity at life's end, which includes ensuring that regardless of one's race or ethnic origin, that they are able to access end-of-life care options that are consistent with their values, their priorities, and their beliefs. And I am excited that we will have some discussion of this later on during the webinar. This is work that we have prioritized over the past 2 years and work that we continue to prioritize each and every day. While as a country, we have faced tremendous loss and death and unfortunate devastation these past few months, this pandemic has had one positive story. That is a story of doctors and nurses and EMTs and healthcare workers being our everyday heroes, caring for each of us and our loved ones under some of the most excruciating circumstances and bringing their whole hearts and their creativity to what has been a very difficult situation. And I and we at Compassion and Choices are really thankful to all of the healthcare workers who have done so much over these past few months. And I'm particularly grateful to the 3 who have very generously joined us on this conference call today to share their expertise and knowledge with us. The challenges of dealing with such a contagious and deadly disease has resulted in very immediate and drastic changes to how medicine is delivered and how one dies. Some of these changes have been positive and some of them have been concerning. And the purpose of today's call is to address both of them. For the past 30 years, we have been on a trajectory of healthcare moving out from behind closed doors. We have really seen a tremendous shift towards patient-directed care. With this pandemic, we now have loved ones and family support systems that are not just relegated to waiting rooms, but in many instances, they're sitting in the parking lot or they're not even in the same, zip code. The greatest fear of older Americans that they will die alone in an ICU or a nursing home, unable to be surrounded by their loved ones, has unfortunately become an all too frequent occurrence. At the same time, we have seen a positive trend, which is that a relatively new type of care, not really new, but more newly adopted type of care, that we believe aligns more with patients' values and priorities for less intrusive care that one can access from the comfort of their own home, has really began to be adopted within medicine, and that is telemedicine. Estimates say that 4 months of the pandemic have advanced the adoption of telemedicine by about 10 years. So the slow adoption of telehealth or telemedicine as a practice has been able to reach a place that otherwise might have taken us as a society 10 years. And this is really promising if you think about the reality that the data shows that most people want to die surrounded by their loved ones in their own home. telehealth is really an option that can allow us to reach that vision far faster. While the growth of telehealth has been extremely promising, there are other policy changes that have not been as promising. One is a waiver of the 1990 Patient Self-Determination Act. And this is an act that was put in place 30 years ago in order to put patients in charge of their end-of-life decisions. It was about bringing greater transparency to end-of-life care. And unfortunately, at the height of the pandemic, CMS waived one of the provisions within the Patient Self-Determination Act that requires hospitals to inform their patients about their advanced directive policies. So we as an organization have joined with others working to reinstate this very important provision so that we can ensure that our care continues to be patient-directed. But at the same time, the pandemic has also shined a light on the reality that we must do much more around advanced care planning in advance of a person arriving at a hospital. So we are also encouraging Congress and CMS to prioritize advanced care planning and to encourage other health entities, nursing homes, assisted living facilities, healthcare providers to also prioritize advanced care planning. Because it is through the prioritization of advanced care planning that we can take the guilt and guesswork out of caregiving, and we can avoid doctors being put in a very unfortunate position of having to make decisions on behalf of their patients without having those fully informed conversations. And it will allow patients to have that final act of being able to declare their values and their priorities. It is the purpose of this conference call is to talk about these and other very important policy changes that are taking place. And what I'm going to do now is turn straight to our guests and give them a chance to talk more about their experiences on the front line. First up, I'd love to hear from you, Dr. Muller, as somebody who's working in New York City. When you think about everything that has happened over the past 4 months, most of us have only had the experience of reading the newspaper. We haven't been there on the front lines. And I'd love for you to share with us your most important memory or surprising moment or some poignant reflection that helps us summarize the experience of providing healthcare, especially end-of-life care during this pandemic. Dr. Muller?
Thanks for the invitation to be here, Kim. I'm really proud to be able to participate in this conversation. So my clinical practice is taking care of people who are homebound. It's a population of patients who are very elderly and frail and historically have not been able to get to the doctor, so we provide them with primary care at home. Within the first few weeks of the pandemic, it became very clear to us that our patients were at high risk of contracting COVID-19 and that they were the worst possible patient in the world to bring to a hospital because of their underlying age and frailty. And so our practice quickly came to the conclusion that we needed to call literally every single patient in our program and have a conversation with them about their advanced directives. Now, that's something that by virtue of who our patients are, we always do at intake. Sometimes you don't get to have the full conversation, but you never really have a conversation about what do you do in the midst of a pandemic. Do you want to come to the hospital if you contract this virus, or would you rather die at home and get palliative care? And if you choose the latter option, I need to give you morphine at home to have now just in case you become symptomatic. And obviously I'm compressing what is a very difficult conversation into just a few seconds. But that moment in time when all of us realized we have to contact all of our patients or their families if the patients did not have capacity to make that decision in the moment was really, really challenging. And yet at the same time was deeply appreciated by all of our patients because that's exactly what they were thinking about.
Wow, Dr. Muller, that really is a model, and thank you. Those patients that you have are really fortunate to have had that kind of experience with you. Debbie, I'm curious, you're working in New Jersey, right across the border, also in a hot spot. Tell us a little bit about your experience or your most poignant moment.
Yes, the hardest part for me was once I went into where they opened up a whole 40-bed ventilator-dependent ICU in a shell of a building that was supposed to be our new ORs. They converted it within 7 days into an ICU with ventilators. And I looked at everybody in there working and in the rooms with the patients working. And I wondered, what are we doing here? Where is this going? Like we were on a roller coaster ride that was so new that we had no idea what this roller coaster ride was going to end up looking like. And that was the first thought I had. The second thought I had was I was hearing a lot of code blues, which is a cardiac arrest, where you return somebody back to life if possible by doing CPR. And then that question became, we have a palliative care team. Are they reaching out to families and having these conversations? I did ask about that because I was really concerned. And the answer was yes. But we were inundated with patients who are on respirators. And it's very hard to talk to families that aren't present. And when you call them back to tell them what's going on, they're not home. And then they call you and the doctor can't talk to them because they're with another patient. And so it's a roller coaster in that way as well. It was very disruptive to really caring intimately with a patient because there was so many sick all at once. I think we've come through it pretty well. And I think one of the lessons we've learned is that mortality does have an end. And we need to be prepared for that by thinking about that now when we are able to think about it. And so advanced directives and patient advocacy is a huge direction that I'm going to be going into in the future.
Wow, that's helpful. And you hear from both what Dr. Muller said and what you said, Debbie, the importance of palliative care as a part of this, of how we're addressing this. And it's nice to see that in both cases there was the palliative care physicians were playing such a proactive role. Dr. Jeff, what was your experience, or what is your experience?
Well, first and foremost, Kim, thank you very, very much. Thank you for our audience for being here and for caring. Deborah Dunn, I am a new fan of yours, as you know, because of your great work and as courageous as you are. And Dr. David Muller, thank you so very much for your focus on older persons and on minority care, and we appreciate you all. My experience was very interesting. I was not working on the front lines. I started working in telepsychology almost as immediately as this virus began going through our population. They closed down the medical school that I was in, and so we had online learning. So the majority of my time was spent working with patients online, of course, and teaching our students. But one client of mine in his 50s, whose grandmother was in her 90s, gave me a call. And she was living in a nursing home. He had not seen her for quite some time. And so they had suspected that she had contracted COVID-19 and transferred his grandmother to the hospital. And of course, with what was going on with the protocols with regard to visiting, was not able to visit and was extremely upset, extremely despondent, and became even more despondent 2 or 3 days later when I received the call from him during one of our sessions that in fact his grandmother had passed away, had done so alone, except for, of course, having clergy working through, behind the glass and so on. And was not really able to say goodbye because they hadn't put anything in place at that point with regard to doing something online. But what really upset my patient more than anything else was that even though we had had previous conversations because of my work with Compassion and Choices around the issues of minority persons, especially not utilizing advanced care directives, this was something that was very upsetting because his grandmother did not have one. She did not name a proxy, and if she had named him, he may not have been able to be there anyway. So he just, the guilt, the amount of guilt that he felt and continues to feel, the grieving is something that was monumental for him, but was certainly a lesson for me that with compassion and choices, that we are moving in the right direction. We are needed, and we are especially needed for older persons, and my concentration, which is a little bit like Dr. Muller's, which is working with minority persons.
Yeah. And that really, it brings up such an important, I mean, so many important points in what you said, but one of the things we hear so often that people, desperately do not want to die alone, but you look at this pandemic and that has been the unfortunate reality. And I'm curious, now that we're through a couple of months, what are some of the things that we're doing in order to limit the number of people who are dying at home if that's not what they want, or limit the number of people who are dying alone if that's not what they want, or helping to still create that sense of closure? Dr. Muller, are there things from palliative care that you guys have implemented that are helping?
So it's Kim, it's a really good question, and it's enormously challenging. I would say one thought I have is the healthcare system itself is not structured in a patient-centric way. At baseline, if a person's going to come to the hospital and potentially be there towards the end of life, it's the worst possible place to be. Even without COVID, even when there are no visiting hour restrictions, it's an awful environment to be in, because it has to be regulated. It's not awful because it's of bad people. It has to be so tightly regulated that it doesn't allow a family to just express their love in the way that they would want. So from the perspective of our program, we do everything we can to keep people away from the hospital. We'll treat them at home. We'll do procedures if we need to. We can set up IV infusion. And if a patient of ours needs to come to the hospital, we make sure that they stay at the hospital as few days as humanly possible. And if they're literally nearing the end of life, we will bring them home to die at home, because we can really, I mean, all of us are aware that we can provide people with all the resources they need to die a dignified and peaceful death at home. In the setting of COVID, I had a couple of patients who unfortunately passed away during the course of that time, 2 of them from COVID and 2 not. And in all their cases, the families could not be there. They couldn't come for risk of exposing themselves or the patient or the home aides who took care of them. And so it was heartbreaking. A lot of crying on the phone and asking me as a doctor over and over again, are you sure I can't come? Is there any way I can come? What if I wear a mask? And it just wasn't safe for anyone. And that was heartbreaking, but it was a reminder of how important it is to be there when it really happens, when the circumstances allow us to do that.
Yeah, that's really important. And for those that are listening now who are not aware, Compassion and Choices developed a COVID-19 toolkit. I actually think Deborah was part of the review committee on it. And one of the decision points that you would talk with your doctor about is, do I want to go to the hospital, or is it possible for me to have treatment at home? And I would encourage you, if you have not thought about it or filled out an advanced directive specific to COVID-19, that you take a look at that toolkit and you take advantage of the CMS telehealth planning codes that allow you to have a conversation with your doctor and put those systems in place. So if you're not fortunate enough to have Dr. Muller as your doctor, or somebody else who's proactively reached out to you, you can take steps on your own to help make that happen. Deborah, I'm curious, as a nurse, whether you've seen any other ways that Dr. Muller didn't address of addressing the not wanting to die alone during the pandemic.
So it's interesting, because I agree 100% with what Dr. Muller said. Patients were left alone, and they were saying goodbye to their family, who were not allowed to come into the building besides dropping them off by the ER. Was it a goodbye, or was it a goodbye, I'll see you later? Nobody knew. And that's a horrible way to say goodbye to somebody. Yeah. We did implement some kind of FaceTime tool. We got iPads, and we got patients talking to their family members. It is far and away not the same thing as being there in person. But a person needs to think in advance about what it is they're going to want should they reach their end of life time. And you don't know when that time is. So certainly COVID hit. That was a surprise. We all got sideswiped. So now that we're coming out of being sideswiped, it's time to think about, I could have an end of life moment around the corner. Let me get prepared today. Let me ask my doctor how you feel about end of life care. What are your priorities and your directions, and where are you thinking? And are they in alignment with mine? Because if they're not in alignment with mine, perhaps I need to change my physician because I need a physician who's more in line with me. So I think we've learned a lot from the epidemic, the pandemic, but I think we have a long way to go. I think we need to open our minds to being educated and to asking questions and going on the internet and looking things up and talking to healthcare providers.
Yeah, thank you. Dr. Jeff, you alluded earlier to the disparities in care that COVID-19 has really helped to, or helped isn't the right word, but that we're really seeing existing among communities of color. Can you talk a little bit about these disparities and any thoughts you have about how we could create greater equity?
Sure, and I think in some ways it brings in what Ms. Dunn and Dr. Muller talked about. According to the Journal of Palliative Medicine in 2016, we found that overall 40.6% of Americans age 50 and older reported having an advance directive. And when they looked at Black older Americans, they were more significantly less likely to have advance directives, less likely to have them, 24% versus white older Americans at 44%. And we know for brown people, Hispanic older Americans, 29%. So, you know, we are really behind the curve on this one. Talk about flattening the curve. We'd like to pull up to the curve. But along with that, we also know that statistics show that when it came to COVID-19, that African Americans were disproportionately affected. They make up a lower percentage of the population, but a much higher percent of the people who contracted COVID-19, along, of course, with older persons. So when you put both of those things together, what you're really seeing is the perfect recipe for disaster. And this is what happened. I thought when I was listening to the title of this program, which is excellent, I thought in my mind another title could be COVID-19, a funny thing happened on the way to the forum. For those who remember Zero Mostel, right? And so this is, I think, what we're learning is that COVID-19 really pulled the scab, you know, off of something that had not healed, that showed that there are all sorts of healthcare disparities, that there are disparities with regard to having an advance directive. So what are some of the things we need to do? Well, following with what both Dr. Muller and Ms. Dunn said, we need to have better relationships in the African-American community, in the Black community, with our physicians and our nurse practitioners, our nurses, and so on, the people who are providing our medical care, because they're the ones who have to say to us, hey, have you looked at an advance directive? We need to be coached in that way. But part of that is we don't trust the health system for many different reasons that we don't need to go into right now, but we need to have more trust. But that's only going to happen when the American medical system really does catch up as far as equities in the way that they provide care. And so it's really going to come down to what our medical providers are doing, what our state attorneys are doing, what it is that we're doing in therapy. I think it's important that psychotherapists, when they're talking about the overall spiritual, emotional, physical health of their patients, they ask them about an advance directive. We've got to think out of the box. We've got to make this happen because, as we know from COVID-19, tomorrow's promised to no one. A couple of months ago, I went to bed on Earth 1.0. One day later, I woke up on Earth 2.0. It's a different game. We've got to be part of it instead of playing catch up when it comes to advance directives.
Thank you, Dr. Jeff. And Dr. Muller, I know you do a lot of work on trying to eliminate bias in healthcare. Anything that you'd like to add to that?
No, I think Dr. Gardner covered it quite thoroughly. My other job other than clinical care is overseeing the medical education program at Mount Sinai. And I think that one small slice of that is the way we teach medical students. What we teach them, who is teaching them, how much history of racism in America and in healthcare we are providing for them as a context for understanding the clinical care they'll provide, understanding why biomedical research science is so biased when it comes to communities of color. That we're way behind the curve in that, and we're trying to chip away at it in our medical school.
Right.
Bravo, well said.
Thank you.
We've talked about a lot of the challenges that are out there, and we are seeing some positive changes coming as a result of the pandemic to the way healthcare is delivered. And I'd be curious to hear a little bit from each of you briefly, like what do you see as the best potential positive change coming from healthcare? And I'll start with Debbie as a result of the pandemic.
For having a husband who passed away, who was having care from home, and then on hospice care, I had to take him in to see his doctor for nutrition. He was getting a feeding through an IV line called transparental nutrition. And so every now and then you have to see a doctor to get the prescription of what's in that formula regulated to what the needs are for the person. That trip for my husband was very difficult. If he could have been able to speak to him by Zoom or any other modality that's available today, that would have saved him a tremendous effort on his part of a weakened body to get him to the doctor's office, who didn't need to do a physical exam. Certainly sometimes you need a physical assessment, and that's number one. But when you don't have to do that, there's no reason why you can't have a FaceTime kind of meeting. So this is a wonderful, wonderful thing that came out of the pandemic.
Got it. Dr. Jeff?
I agree wholeheartedly. I think now's the time that we're finally focusing on, yes, we know all lives matter, but we really need to focus on with the inequities that have been covered, that have been uncovered by COVID-19, right? That Black lives matter. And therefore, I can tell you, power to the people. For too long, Black people, especially older Black people, have not had access or cared to or were afraid to get onto computers and to look up information about advanced directives or medical aid in dying or any of the things that so many other people have access to. So now that we have telemedicine, telepsychiatry, telepsychology, what we're doing is we are forcing older persons like myself to actually learn how to do Zoom, to actually learn how to look up information, to actually be empowered on the computer. And I believe once they do that, it will open a portal for them, no pun intended, to be able to then find out more about advanced directives, to learn more about the other things that are important as far as getting good medical care. Not only will they have better access to care through telemedicine, but I really believe it will give them the information they need to start gearing themselves up for the future.
Thank you. Dr. Muller?
So I'm going to take a little bit of a departure. I guess maybe I'm also more of a skeptic. I think that things like telemedicine are valuable tools, but within a system that is structured to bias care, they're going to end up in exactly the same place. And I can't predict exactly how that will happen, but telemedicine will be one more way that we separate out advantaged from disadvantaged, privileged from underprivileged, Black from white. And so I worry that believing too much that it is one of the answers is going to end up in the same place we've been all along unless we really dig down deeply into the roots of medicine and medical practice and make some of those changes. So it doesn't really answer your question though, Kim. For me, the thing that has come out of COVID-19 that is good is I think we have learned to really appreciate each other more. We've learned to say thank you. We've learned to say I love you. We've learned how important it is to be in the same room with people, to be able to touch them, to hold their hands. Missing that, I think, has opened up a world that many of us, for maybe even a generation, have neglected too much or have taken for granted and no more. If we can hang on to that, I think that will be one of the drivers of our personal and institutional values that will force us to use things like telemedicine, for example, in the best possible way and not just as another intervention.
Yeah, so greater humanity as a result of it. That's a really, really well said. So we are at a time when I'd like to open the floor up for questions. So I'm going to turn it back over to you, Matt, so we can be sure we have plenty of time for our participants to ask their questions.
Sure. Well, first, just thank you everybody for those comments. I had to put my notepad down to get to the question portion because I was furiously scribbling quotes. So I'm glad that this is recorded. So thank you everybody for those comments. We've had a lot of questions around the theme of advanced care planning and around advanced directives. And one question that's kind of come up consistently directed towards Dr. Muller has been about how you are seeing advanced directives instituted and used throughout the crisis. So are people's advanced directives being sought out, utilized, or is there a reflex within medicine in this very emergent circumstance to move towards heavier treatment that you might have not seen previously outside of the pandemic?
It's a great question, Matt. Thank you for sharing it. So I would say that certainly, at least in our health system at Mount Sinai, and I can only speak to what our experience was here, from almost the very beginning, the palliative care program here swooped down and made sure that there were algorithms and information and material available so that doctors, even in the emergency room, even at intakes, certainly in the ICUs and on the wards, knew exactly how to frame those kinds of discussions, had honestly what was a small army of residents, doctors, and medical students doing phone calls and telemedicine to have conversations with families, not just to update them on the well-being of their loved one in the hospital, but to begin to have those conversations as well. So I saw it happening a ton. It became a much bigger part of typical clinical practice than it ever has been before. And I'm hoping that that stays true even moving forward.
Great.
Yeah, and I'll just add that we have heard and seen a rise of palliative care taking place as a result of the pandemic. I do suspect that the experience at Mount Sinai, because of the strength of Dr. Muller's program, is probably not the typical experience, but I have heard quite a bit about the rise of palliative medicine as an entity across everything. I'd be curious if Debbie, you're in a different type of a system, kind of what the experience is there.
Oh, it's the same across the board. It's not unique. You know, our hospital may be a community hospital, but we still function similarly. We don't have the residents. We have doctors who were heavily involved with the patients and their needs and talking to the families. It was disheartening though, because I also took telephone calls from family members who weren't able to speak to their nurse even because of the craziness of COVID. So we were inundated. Truly, that is the right word to describe it. That did not allow us to meet with the needs of the families because the nursing care was so that they could not get to the phones. They were very busy taking care of the patients and there was no time to speak to the families. So when I was speaking to the families, they wanted to know what was going on. And it was hard to get them to connect with the physicians. So that is a big difference between a hospital that's a teaching hospital that has the residents and medical students and more people around to help with that kind of care. But we had nurse practitioners coming forward and PAs, and we took people in from out of state who came in and started helping us in our hospital as well. So there were many different ways of approaching the puzzle, but you know, sideswipe once every 100 years, even though it's a long time since the Spanish flu, we need to be more prepared for next time around. We need to be ready for another incident similar to this. The infectious disease doctors are predicting this for a long time.
Beautiful. Along the same lines, thinking about advanced directives, you know, Kim, you brought up this change in the law around the obligation for facilities to provide information around advanced healthcare planning. And so a couple of people have asked, Kim, you know, what is the status on advocacy around getting that added back in when it comes to HHS? And then what has the impact been? So two-part question, one for Kim on the advocacy side, and then for Dr. Muller and Debbie, you know, have you seen the way that you're dealing with advanced healthcare directives change due to that regulatory change, or is this something that has hopefully not been the case?
Yeah. So on the advocacy front, we've sent a letter to CMS and to Congress. We have a lobbying effort that's happened at the federal level. We have several different organizations who've joined with us in these efforts, and we've gathered about 5,000 signatures. It is a temporary change, so it's supposed to go back into effect at the end of the pandemic. The concern would be if it went from temporary to permanent, which of course many of the telehealth provisions that we're favorable towards were temporary and could become permanent. The change itself gives the hospitals discretion. We do not anticipate that somebody who has an advanced directive would show up. It doesn't mean that that advanced directive would not be honored. It means that hospitals have the flexibility to be less proactive and share their advanced directive policies. And our hope is that few of them are taking them up on this as an offer. But the fact that the change was requested by somebody and has been made is what's so concerning about it. I would be curious to hear whether it doesn't sound like it has come into effect with Dr. Muller at all, from what I'm hearing, or even Deborah. Is that accurate?
Yeah, it didn't come into effect at all. I mean, look, at the end of the day, we all recognize that it's good clinical practice. Talking to people about end-of-life care is good clinical practice. And in some settings, talking to patients about aid in dying is good clinical practice, period, regardless of what the policymakers say. So there was no impact at all on our practice at Mount Sinai.
And from my perspective, it really is about you being an advocate for yourself. So you need to also be aware that you need to take charge of getting your own advanced directive, and you need to be sure to bring it to the hospital when you go into the hospital and say, here is my advanced directive, put this on my chart. No hospital is going to return that back to you or decline it. So you need to advocate for yourself and what your desires are and speak up. The hospitals are very busy and aren't worried about whether they should talk to you about advanced directive, offer to you time to help you prepare one. So that's not something that I think is a real problem right now, but you again need to take charge of your needs.
Dr. Jeff, we have a question. You know, you're America's psychologist, and America right now is facing not just the pandemic, but also a pandemic of isolation, loneliness, of being separate from one another, those of us that we love. And so there've been some questions about, you know, what impacts you're seeing when from that long-term separation and what we should expect. And then for those of us who are looking for ways to cope with that isolation and separation, that feeling of grief and loss, what are some of your pieces of advice and wisdom for us?
Well, we do know that older persons have either been isolated by family or isolated themselves, and that they begin to lose loved ones, going into a nursing home situation. Of course, we know that the staff can become family members, but quite often we, as the younger members, generations, may begin to leave our elders in those places, not visit as much, not call as much. And therefore, what we saw with this social isolation, following the CDC guidelines with regards to distance and who can visit and so on, made an already very bad situation when it came to depression and loneliness. This social distancing and these precautions made it much, much, much worse. But it also affected people who didn't think about social isolation, people now who had to shelter in place and so on. And so the advice that I gave so many people, my patients or working on the news, was that socially distancing doesn't mean having to be alone. If you're able to, of course, connect with as many people as possible. You can do that through the social media, social platforms. You can do that by telephone. It's important that you touch base with as many people as possible. And I think one of the byproducts of or after effects of COVID-19, and I think Dr. Muller talked about this a little bit, the whole idea of face-to-face, being able to touch. But even if you cannot touch, even if you can't reach out of the darkness and reach out and touch that person, using the computer, using your telephone. I mean, these things are handheld computers, right? Remember those from Star Trek? You know, beam me up, Scotty. Now, you know, we know that these things are so important to staying connected. So I would tell everyone, stay connected as much as possible. And for those who may not have the wherewithal, please stay in contact with them and make sure that they're okay.
Well, thank you. Well, you know, in hearing each of you talk about various impacts and things, I wonder if we could ask kind of one final question to each of you as we think about long-lasting impacts, not just what you're seeing in the short term, but what you see as long-term change that could come about in this moment of contraction. What is our expansion that we see coming on the horizon? So what do you think will be really the most meaningful long-term shift or impact in medicine and healthcare as a result of the experience of this pandemic, particularly when we think of end-of-life care and how we die in the United States? And so I'll ask it to each of you. Debbie, what do you see that long-term shift being?
I'm hoping it's about advanced directives. I'm hoping it's about people saying, this is my life. This is how I want to have my life lived. This is my end of life coming. This is what I want for my end of life. And I want people to be able to think about these things when they're cognizant and they have the wherewithal to think about it. And most importantly is to share it. So if you keep these things to yourself and you have an advanced directive, and then your family, you have a healthcare proxy and you've chosen somebody to speak for you, but you never spoke to them. They really understand what you want by the communication you have with them, not a piece of paper. So your family can execute what you want by sharing with them. And that is my focus for where I want to go with this at the end of life, is to also share it with your family so it's not a surprise. They're all on the same page as you are. So you have met what you want when your end of life maybe comes around the corner.
Beautifully said. Thank you, Debbie. Dr. Muller, long-term impact.
So this is a little bit different from what we've been talking about. I think that the advance of aggressive care, instrumentation, interventions has happened persistently but gradually for the last probably 20 or 30 years in American medicine, to the point where it's that drip, drip, drip of water that you just don't notice anymore. And we find ourselves as a nation providing a ridiculous approach to medical care at the end of life or for critical illness. Ridiculous because the vast majority of times we know that it doesn't work. And what this pandemic has done is, instead of that drip, drip, it's washed us with a tidal wave, almost like a wake-up call to the medical profession, saying, look at what you're doing. It's futile. And it's not just futile because in some cases of COVID-19 infection, all that stuff doesn't work. It doesn't work a lot of the time. And I'm hoping that somewhere in there is a wake-up call to us, to the providers, to the doctors, nurses, the profession itself, to say, let's take a step back from all of this aggressive critical care and decide, when does it really make sense? Because it doesn't make sense most of the time. And this is an opportunity for us to have kind of a paradigm shift in the way that we think about providing that level of care and being much more thoughtful about that versus what Debbie said, which is sitting down with people and really investing the time in understanding what do they want for their own medical future.
Wow. Yeah, well said as well. I didn't think it could get better than Debbie's, and then something equally as meaningful. So thank you, both of you, on that. And Dr. Jeff, long term.
Mine won't be as good as Deborah Dunn and Dr. David Muller, but I would say in the medical schools, in the medical school in which I teach, we talk about cultural competence, cultural sensitivity, community service, and so on. This is now at the forefront of medical education. every once in a while, I've heard from many professors at medical schools when they talk about cultural competence, because they don't look at it, the students don't look at it as hard science. They, sort of roll their eyes. Well, I haven't encountered that. That hasn't been an issue in my community. Or listen, I'm more worried about organic chemistry at this particular point, not about cultural sensitivity. But I think if nothing else, COVID-19 has pulled the curtain off the fact that cultural sensitivity, cultural competence, equal medical care, disparities in healthcare must be addressed. We saw that people of color, Black and brown people, were disproportionately affected. And so along with that came the whole idea, again, resurrected, that Black lives matter. And people have, and appropriately, have placed that towards justice, an equal justice system. But the way that I look at it, being involved in this particular work, is if we want to talk about Black Lives Matter, let's talk about this disparity in people given the information, assisted in getting the information, and actually being able to establish advanced directives, because again, we see that it's disproportionately lower for Black people. Therefore, the push must be, if we want to talk about equality in the health system, the importance of palliative care, the importance of not getting expensive and unnecessary medical care, the importance of not having to suffer at the end of life for no reason other than just to keep someone moving in a direction which is absolutely no direction. At that point, there is no hope. So this, I believe, has to be what we need to do. We need to work with our professors. We need to work with, as I said, state attorneys, but we also need to work with politicians, and we need to work with clergy, because again, religion is a major reason that Black people may not have the advanced directive thinking or directives thinking, well, it's in God's hands. And I will say this, as an interfaith minister, God helps those who help themselves. So let's please address this in a holistic manner and bring equality to medicine and medical care as we see it for all people.
Wow, thank you so much. You about had me jump out of the chair saying amen a couple of times there. So thank you, Dr. Jeff, for those comments. And then finally, Kim, as a leader in this movement, where do you see the long-term shift happening?
Well, it's always hard to go last, especially after such eloquent people. But I'm going to piece together a little bit of what everybody said. But for me, what comes up as I listen to everybody talk and as I have been experiencing things over the past 4 months is a reality that people are much more aware of the fragility of their own lives. So this idea that mortality, that we live forever, is gone. And that at the same time, as Dr. Mohler said, you've got health professionals out there who are starting to recognize the balance between quality of life and quantity of life and think more about the kind of care that gets delivered. So I think coming out of the pandemic, what we are going to see is much greater passion and intensity around end-of-life care and choice, and the movement is really going to take off. People are not going to just want to plan more, but they're going to want to have greater autonomy, greater compassion, greater decision making, and we see that each and every time somebody has an experience with a bad death, and there's a lot of people now who are experiencing that, and they're going to recognize and understand why it's so important to be able to say goodbye to your loved ones, and why it's so important to be able to plan for and chart your own end-of-life experience. So I believe we're going to emerge from this, and the movement that has already been moving along is going to become much stronger and more robust, with people of all communities coming together and uniting around a desire to have end-of-life care that's consistent with their values and priorities.
Oh, well said. Thank you, Kim. And thank you to all of you. It's my job to kind of close out with the ending housekeeping, but Before we do that, I just have to sit in gratitude for everything that was said today and for the time that each of you, Deborah, David, Jeff, and Kim, the thoughtfulness of your comments. And I know that I speak for all of us who were watching, the over 200 participants today who were here live, and the hundreds of others who will mull over this in the coming days, weeks, and months as they weigh these incredibly important decisions that they're making in their own lives and with their own families. We are all grateful for all of you. So we thank you so much for your insight and everything that you shared with us, and for taking the time to do so thoughtfully. But it is my job to kind of close things out and to talk to all of you about some resources that exist here at Compassion Choices. If you are mulling over these decisions and you are needing a place to start. So first, on our website, compassionchoices.org/end-of-life planning, as you'll see on the slide that's up, we have both the Plan Your Care Resource Center, where we have documents and guides around starting these conversations, as well as our Tools to Finish Strong, which are incredible customizable tools for engaging in these conversations with clinicians, as well as taking a step in planning for the end of life. And if this is your first time hearing about these pieces, this is a great place to start. And there's something there and some step that each of us can take. If you are needing a little extra help and some support, or you have some questions, we're also here for you. We have our end of life consultation service, which is available at our 800 number or by emailing us at eolc@compassionchoices.org. And we have trained consultants who can provide education and emotional support and guidance as you move through your process, whatever that might be. We also have created a toolkit, an extensive toolkit specifically related to the pandemic, to COVID-19, and to where we are. So some documents about understanding it, understanding all of the different options that are now available, as well as how to approach these conversations about advanced healthcare directives in light of knowing what we know now due to the pandemic. And so much of the wisdom that you've heard in today's webinar has been condensed down into some of those documents. And we're fortunate that some of our speakers today were a part of creating those documents. The other thing I want to invite people to take part in is to continue this dialogue and this community that we have through our Staying Stronger Together webinar series. Coming up on June 16th, we have an advocacy focused webinar about how you can use your online presence to inspire action. So maybe you're someone like me who likes to show up in person to rallies and lobby days, and you're going, what do I do now that I have to be 6 feet from people? How do I use my voice in new ways? That webinar is about how to do that in a powerful way. And then on June 25th, we were just talking about our end-of-life consultants. You know, they answer hundreds of questions from across the country every year. And they're putting on a webinar called Ask Me Anything, where we're going to go through some of the most common questions that we get around end-of-life care, as well as take your questions for them about end-of-life care. So make sure that you join us on June 25th for that. If you haven't had the chance to tune into some of our previous webinars, or if you're going, you know, this was really good, I need to send it to this person, this person, this person, this person, you can go to our website and we have all of those archived there and recorded so that you can, again, watch again or share those with other folks, or just look and see all of the host of topics that have gone on. You can also follow us on social media. We're active on Twitter, as is Kim. Kim's been doing a great job during this time that we're not able to be together in person, and sharing new resources and articles and comments on things and good commentary on her Twitter page. So I encourage you to follow her if you're looking for thought leadership around end-of-life care. You can also join us on Facebook, on YouTube, on Instagram. We are active on all the social media platforms. So whichever is your preferred method, we invite you to engage with us in that way. And with that being said, I hope that it is evident as we talk about the work that we've been doing and the ways that we have been utilizing technology to continue to connect with you and to continue to try to show value in your lives and to experience the value that comes in interacting with you. Compassion and Choices, despite this pandemic, we are still working. In fact, we are working incredibly hard on behalf of those who are at the end of life and who are approaching these decisions and who we know do not have equitable access to the care that they need. So if in hearing today's webinar, you are moved, or if in watching our work throughout this pandemic, you are moved to support us financially, we currently have a generous supporter who is matching all gifts 1-to-1 through June 30th, which is coming up very soon. And we invite you to make a gift that's meaningful to you by going to our website at compassionchoices.org/give now. As I said, we remain committed and we remain active and we remain vigilant in the work that we do around making sure that your rights are honored and that you are able to chart your own journey at the end of life. So again, if this work is meaningful to you, if what you heard today is something that resonated, we invite you to support us in that way, if that's something that's something you can do right now. So with that being said, I will close out with the same gratitude that I voiced for our speakers, for all of you, for again, allowing us to come into your homes today to share what I hope were some interesting insights, and ultimately just to be in community with one another. It is a gift to us to know that you are there, and it is, I know, a gift to all of our speakers to be able to share this information. So with that in mind, we'll close in gratitude. I thank you all, and I look forward to seeing you on future webinars. Thank you to our speakers for all that you contributed today, and be well, and blessings to all of you.